Still trickling in, but I'll go ahead and kick us off. Just want to welcome you all to our hot topic session, Metabolic Health Advancements and Equity, hosted by the BRE Collaborative, which is housed under the Foundation for Healthcare Quality. I'm Beth. I am kind of in the corner of the screen over here. We wanted to show our beautiful conference room, but I use she, her pronouns, and I'm the Director of Research and Best Practice for the Foundation, primarily supporting the BRE Collaborative. I just want to thank you all for being here today to participate in this discussion. As to kick us off, I just wanted to address some housekeeping items so that the event runs smoothly. We ask that since this is a group discussion format on Zoom, it's not a webinar format, that you do have the ability to come off mute to come on camera, but we just ask that you please mute your microphone and save any questions for the open Q&A for our panelists during that portion of the event, and that you raise your hand but until we get to the group discussion section where it's more of an open space. And this event will be recorded and posted on our website for viewing later on. And we do highlight the BRE as a neutral convening space. And so we don't allow any solicitation or promotion of products or services while we're in these group discussions. There we go. So our agenda for today, we'll start off by reviewing the learning objectives and going over a brief overview of just what GLP-1 RAs are and continuous glucose monitors. So we have to come to this space with sort of a shared understanding. And then we'll jump right into our panel discussion. We'll let our beautiful panelists today come on and introduce themselves. And Cora will lead some questions for them. And then we really invite people on the call who have their own questions to raise their hand, come off mute, ask them of our panelists. And then, there are many questions that people have for the community at large. And so we invite questions that are more directed for group discussion to occur towards the end of the meeting. We'll also, at the very end, invite you to fill out a post survey to provide some brief feedback on the event today and some things you might want to see from the BRE for these kinds of discussions in the future. So briefly, we'll start off with our learning objectives. So we're hoping to describe the current state and future trends of GLP-1 RAs and CGMs and their impact on weight management, diabetes prevention and management. Identify some of the main barriers of facilitators for accessing and utilizing these advancements among different populations, especially those who are more disproportionately affected by diabetes or weight health concerns. We want to be able to discuss the roles and responsibilities of various stakeholders, including employers, providers, plans, and community organizations, and promoting equitable access to and use of these technologies and advancements. And really share some best practices and lessons learned from implementing or participating in programs or initiatives that leverage these to improve metabolic health outcomes for individuals and at a population health level. And so to begin, like I said, we'll share just a brief introduction to what these topics are, so we kind of have a baseline understanding. We're here to talk about specifically GLP-1 receptor agonists, otherwise known as GLP-1s, and continuous glucose monitors, or CGMs. So GLP-1s are a class of medications that mimic the effects of the natural hormone glucagon-like peptide 1, and they stimulate insulin secretion, inhibit glucagon secretion, slow gastric emptying, and reduce appetite. They are used to support blood sugar control, and were originally approved for the treatment of type 2 diabetes several decades ago. They also produce weight loss in higher doses in conjunction with lifestyle modifications. Some formulations specifically for weight loss have been cited at higher costs to both purchasers and patients, which is one of the several barriers that can lead to different use across different populations and for people that have the highest potential benefit, such as patients with cardiovascular disease. Continuous glucose monitors, on the other hand, are advanced glucose monitoring technology that continuously measures interstitial glucose levels, display current blood glucose levels, as well as the direction and rate of change, and use alarms and alerts to inform patients when blood glucose is exceeding or falling below specific thresholds. CGMs can help patients with diabetes adjust their insulin doses, prevent hypoglycemia, and improve glycemic control. There have been historically several barriers to their use, such as cost and coverage of the device and sensors, limited awareness of the technology, or even when trying to communicate with a physician, access to internet connection can be a barrier. A study recently published by the ADA found that there were some differences in individuals covered by Medicaid being likely to get coverage for a CGM or use a CGM. Such as states with a higher percentage of white Americans are being more likely to have better CGM access than those with higher populations of Black Americans. The Washington Health Technology Clinical Committee under the Healthcare Authority recently chose continuous glucose monitors as one of their topics for re-review in the coming year. And with that, I would like to turn it over to our intern this year, Cora Espina, to introduce herself and introduce our panelists as well.
Thank you, Beth. Now, my name is Cora Espina. I use she, her pronouns. I've been a nurse practitioner for 16 years and a registered nurse in total for 24 years. Most of my clinical practice has centered around diabetes care and policy improvement within my organization. I've worn many hats and have worked in various settings. Really, what I'm most interested in now is cross-sector collaboration with a lens focused on equity. And I'm working on my doctorate at the University of Washington and currently interning at the Brady. So thank you. I'll be leading the panel discussion over the next half an hour or so. And so what I'd like to do is have each of our panel members introduce themselves. And when I invite you to speak, maybe first tell us your name, the organization that you work for, your role, pronouns, if you care to share with us. And then also maybe what communities or organizations do you typically serve? And with regard to GLP-1s and continuous glucose monitors, or how is that showing up in your practice? So we're waiting for one of our speakers, Dr. Wright. So let's start first with Catalina. Can you start with your intro, please?
Absolutely. Hi, everyone, and thanks so much to the Bree Collaborative for this invitation to participate in this discussion with you all. Particularly look forward to everybody's questions. As Cora said, my name is Catalina Gorla. I'm the co-founder and CEO of True Data RX. We are a data analytics company based in Vermont, but serving everybody across the country. And we particularly, in terms of the communities that we serve, we work with those who pay for drugs. And in the United States, that's primarily employers on the private side. We don't work in the Medicare Medicaid space, so I can really speak and looking forward to specifically questions of challenges employers have in providing access to these medications while meeting their fiduciary obligations to the plan.
Great, thank you. Dr. Scher?
Yeah, thanks for that. My name is Ellen Scher. I am a physician and a researcher at the University of Washington, where I'm a professor of medicine. I trained as a general internist, and I practiced primary care at Harborview for about 13 years. And now my practice is solely obesity medicine, and I practice at the Center for Weight Loss and Metabolic Surgery at the UW. So in terms of who I serve, I'm serving the referring physicians as well as the patients that I see. And the majority of my patients have multiple medical conditions related to their weight and are coming to me for assistance with weight loss. In that role, I am using GLP-1 agonists pretty frequently, both for patients with diabetes and without. So for the patients with diabetes, we're trying to transition them off of medications that might promote weight gain, like sulfonylureas or insulin therapies. and on to our newer agents that can have a benefit for weight loss, such as the GLP-1 agonists or what's called SGLT2 inhibitors. For patients with obesity, I'm prescribing the FDA-approved agents, and these are really, in our practice, a tool that is opening up a use of pharmacotherapy for an extent of weight loss and a degree of weight loss that we have not had the option of achieving or helping our patients achieve in the past. And really is starting to or approaching what we get with bariatric surgery, which is sort of the gold standard for a large and sustained weight loss. So it's been kind of a game changer in our field in that regard.
Thank you so much. Thank you, Dr. Scher. Appreciate that.
Thank you. Dr. Wright's just finishing up with clinic, so as soon as she pops here in a couple of minutes, I'll let her introduce herself. But I think we can still get started. I just have a couple questions, general questions for both Dr. Scher and Catalina. And so they are, what are the barriers you're seeing for accessing and utilizing metabolic health technologies among the populations you serve? And really, how do these barriers impact outcomes and quality of care differently for different populations? So maybe Dr. Scher, we'll start with you, and then we'll go to Catalina next.
Sure. I think probably most people on this call, are aware that there's a difference in, coverage and cost, and for that reason, access for patients with diabetes and patients with obesity. So I'll try and sort of distinguish between those two as I talk today. So for patients with obesity in particular, the coverage, cost, and availability are the main barriers. So most of you will know that when we're using these medicines for obesity in patients who do not have type 2 diabetes, they're typically excluded from the majority of plans, which do not cover therapies for obesity. And this is sort of irregardless of whether the patient might have other types of serious comorbidities, whether they're pulmonary complications, cardiovascular disease, or disabling sort of orthopedic complications. Those folks do not have access to GLP-1s if they don't carry a diagnosis of diabetes. So it puts us in sort of an awkward spot. I once caught myself doing sort of a fist pump when my patient's A1C came back in the diabetes range. And I think that's a good sign that there's really kind of like something wrong in the system when that's going on. So access and coverage is one of the main things, of course, cost. And when folks if they're able to consider paying out of pocket, that's really a very small percentage of people who can access these therapies in that manner. And then the last thing in terms of a barrier most recently has been availability. So demand has sort of outstripped the company's ability to produce and distribute these medications. And we have issues with people going on and off medications, needing to switch to a different dose. Again, this is going to differentially affect certain of the patients. Folks who have time to call multiple pharmacies or, go around town and find the medication are going to be able to still access it when availability is low. And folks who don't have that capacity are going to be going off the medications or having periods of where they're just not able to find them. So those are some of the things that I've seen in terms of barriers. What it means in terms of outcomes, which I think was your next question, and how quality of care might differently affect these different populations. So for patients with diabetes that I'll talk about briefly, those who are able to access these highly effective GLP-1 agonists are seeing benefits for weight loss, and there's a dose-dependent effect on their A1C reduction. So medicines like semaglutide, medicines like tirzepatide, which is what's called a dual agonist, have not only greater weight loss, but greater A1C reductions. So access to those can impact the benefit that people see in terms of the health benefits of the medications. For folks with obesity, we're really talking about the degree of weight loss. Remember that when people are losing weight by lifestyle alone, they lose between 5 and 10%. And that can lower blood sugars, it can lower blood pressure, but there are other types of health issues, folks who have fatty liver disease, that's progressed inflammation, folks that have sleep apnea or degenerative joint disease, they really require weight losses of 10% or more. Our newer agents are really the only ones that are regularly helping people achieve and sustain that degree of weight loss. So we see larger weight losses with greater cardiovascular risk reduction. We see greater across the board reduction in comorbidities when people are taking these more highly efficacious agents. So lacking access to these agents really means if you're going to use weight loss as a tool, you're going to have a less benefit for treating or alleviating, significant health concerns like metabolic liver disease, cardiovascular disease, and others.
Thank you, Dr. Scher. That was just, it's so important to have your perspective. I know we have a lot of clinicians on the call today, and I think that you gave really real world examples, and that kind of translates to a lot of the people on the call today. And just what I noticed in hearing you talking is, while you're a specialist with regard to obesity, there's a lot of overlap in your work. And so same question, Catalina, and then just kind of remind us, so with your work in comparative effectiveness, for those of us that may not be as familiar with that method of work, sort of as you answer these same questions, maybe kind of tell us how that shows up in the people that you're interfacing with. And I can repeat the question.
I think I got it. No worries. Correct me if I don't get it, of course. But
Okay.
I'll start with just a little bit of what we do. It's a little bit unique. So Cora, to just kind of level set for everybody. So we specifically, as a data analytics shop, focus on a field of research called comparative effectiveness research, which is a type of a methodology of evaluating the efficacy of medications, but also of any intervention, medical intervention. Anytime you have 2 or more treatments, you might want to know which one's better. And this is the field of research that is utilized to both statistically and medically provide that assessment. So similar to how we look at the tech specs of computers before we buy them, like how much memory, how much RAM. This is the equivalent of that on the medical side, and when looking at the comparative efficacy around benefits, but then also comparative safety around harms. So in terms of barriers, just to get specifically, and I'll speak more barriers to fiduciaries, because that's who I interact with on a daily basis. And fiduciaries specifically of plans. One, of course, the biggest barrier is cost for us too, just as Dr. Scher said, for patients is cost, but it's also the same barrier for fiduciaries. There's a nuance in that fiduciaries have a very clear obligation, not to an individual, but to the entire plan. And so they have a different type of constraint than a clinician would have, where they have to make decisions that are in the best interest of the plan. And that is the rubric by which they're evaluated. And so a fiduciary has, importantly, unlike a clinician who has a responsibility right to the end of one, to the patient, what's right for this individual, a fiduciary has an obligation more at a population level. And their barriers when it comes to cost is on 2 fronts. What should they be covering? And on the second front, who should they be covering it for? And so today, one of the big problems is that the main way we decide coverage of medications is cost. If a drug is not terribly expensive, we don't really talk about it. It doesn't really matter, right? If these GLP-1s came out and they cost the same as a sulfonylurea, nobody would have invited me to come to this conversation. It would not be a fiduciary decision. It would certainly be a clinical decision, but it wouldn't enter into the fiduciary realm. But because of the cost differential, fiduciaries have to take into consideration some other data point. And this is the problem, is when you're just looking at cost, what you are lacking is that data-driven endpoint. So one of the valuable things that comparative effectiveness can do for these fiduciaries is to take another level beneath the surface. So if the question is, do we cover GLP-1s? That is very hard to answer just as a class. What comparative effectiveness can help plans do is actually evaluate within the class, well, which GLP-1s, do they all work the same, or which ones work better, which ones don't work as well? And in fact, I've got a couple data points I'll share. So with respect to weight loss, there are 3 GLP-1s that have gone to the effort of running studies in the general population for weight loss and have therefore are granted by FDA approval to market their drugs for that use. But on one end, there's one GLP-1 that, as Dr. Schur said, is approaching bariatric surgery in terms of pounds lost. There are almost 50 pounds lost on average in the clinical trials that they ran. But in the other end, still a GLP-1, less than 10 pounds lost. They're both GLP-1s, but you can see there's a really big difference in terms of efficacy. And that's where comparative effectiveness research can help plan sponsors, fiduciaries understand, okay, if I'm going to pay $15,000 for one and $15,000 for the other, you might want to know, what am I getting for that? And that's where comparative effectiveness can really help. On the other side of this is who to cover this for. How do you actually create coverage policies that extend from the population level using the data to figure out where this works? This is where, again, comparative effectiveness can come to play in understanding the safety profiles. These drugs are relatively new, especially compared to other agents that are out there. And there are very significant safety concerns that have to be considered before rolling these out to the broader population. And those are things that can be accommodated for in the who to cover side point. And that's where, again, comparative effectiveness can help to identify what those safety concerns are and incorporate those in policy coverage decisions.
That's great. Thank you. So I have a question for Dr. Schur, and it's 2 parts really. And that is, so you talked already about the benefits of GLP-1s and the costs associated. I'm just curious, how do you navigate discussions around cost and access with your patients? And how can organizations create systems that prioritize patients with the highest needs?
Yeah, those are both really interesting questions. And, it's a difficult time to navigate, this situation right now with patients. And, that's a combination of all the media attention that's come to some of these agents and really sort of the sensitivity of the topic to begin with, both on an individual and kind of a societal basis. So it can be tricky. For me, I emphasize, really being transparent and honest about what the situation is. So we know the medications are highly effective, but that both cost and availability are really a struggle right now. So I might, for example, check to see what the person's coverage is so that I'm cautious in talking to them about this as an option, since it will be cost prohibitive for the majority of patients that I'm seeing if they don't have any coverage, and even sometimes if they do. So I can sort of offer the older medications that might be more cost effective, but I have to set expectations about what the degree of weight loss that is expected. So those conversations, I just try and be really straightforward and honest. I think that I still hope that over time, there will be greater accessibility, and there are other molecules that will be cheaper and easier to mass produce, that will be oral options. So I think that this field is really going to evolve, and these conversations are going to change over time. At least that's my hope. But for right now, we're in this interim period where we just have to be cautious about folks and offer them something that might be more accessible as a bridge to the time when hopefully we'll be able to offer them some of these agents. As we're thinking about, the systems that might prioritize patients with the highest need, right now, that's the point that we're at. So, I do take care of patients with even, life-threatening complications of obesity. For example, that need to be listed for a heart transplant, or have multiple pulmonary or cardiac complications, and so that is going to receive the highest attention and priority from me. But I think across the board, the goal is sort of ultimately, to provide broad access for those that meet FDA criteria for pharmacotherapy. And I think that existing guidelines, about prioritizing the use of pharmacotherapy are a good model for how to prioritize the use of these highly efficacious agents. So, for example, in guidelines like those from the American Association of Clinical Endocrinology, they sort of map out individuals with obese who would qualify for pharmacotherapy according to the presence of comorbidities. So as you escalate from no comorbidities to moderate comorbidities to serious comorbidities, what you do, particularly when people have one or more serious comorbidities, is you start your pharmacotherapy concurrently with weight loss. And what that does is is more likely to produce a larger weight loss, because it kind of improves that slope of initial weight loss. And that same logic, provides a way of thinking about these highly efficacious agents. So what we see then is, there are individuals who are going to get the maximal benefit from the medications that can be prioritized by a system. And there are other folks who, may be able to achieve a health benefit with a lower degree of weight loss that could be supported either by other agents or by behavior change alone. So I think that's one of the models that we can look to that's already existing in the current recommendations and guidelines.
That's great. Thank you. That's so useful. So thanks for that, Dr. Scher. And this is a perfect transition because I'd like to introduce our third panel speaker. Dr. Wright, I'll let you just talk briefly about your background, in particular, what communities and organizations that you serve, because as you may know, one of the main missions of the BRE Collaborative is really like equitable access to evidence-based care for all Washingtonians. And so we've been hearing a lot from Dr. Scher and, your specialty related to obesity. And so, Dr. Wright, we're particularly interested in sort of your equity piece, given your work in the diabetes population and your group. So go ahead, please tell us a little bit about yourself, Dr. Wright.
Thank you so much. Yes, I'm so happy to be here. I am an adult endocrinologist, and I practiced most of the time at the Diabetes Institute. Within the Diabetes Institute, I'm the founder and the director of the Latinx Diabetes Clinic. So this clinic is really an initiative, and the goal when we created this clinic was to reduce some of the healthcare disparities in the Latinx community regarding diabetes and all diabetes complications and other metabolic issues that affect the Latinx community. So our clinic sees Latino patients with diabetes and also pre-diabetes. And one of the strengths of our initiative is that if the patients do not have insurance and patients do not qualify for any programs, like if they don't qualify for Medicare or Medicaid or any state program, then we provide financial assistance and the visits, the labs, the medications, and referrals to specialists are all covered by the University of Washington. So the goal of the clinic, right, like, is to provide equal care. And we also focus quite a bit on the cultural aspects of diabetes. We try to assess, the barriers that the patients may face, and then we work on that. Like, for example, transportation. And if a patient is having issues with transportation, we try to come up with solutions and solve that problem. So as I mentioned, I am an adult endocrinologist. I also have a diabetes clinic where I see patients from all ethnicities and groups and many different types of diabetes.
That's great. Thank you, Dr. Wright. So Catalina, I wanted to ask you a specific question. And really, what are the gaps in the evidence base when employers are making decisions around pharmaceutical and technological advancements?
Great question. So there are kind of two main gaps. One is what they're seeing in terms of the options. And I think there's as Dr. Schur mentioned earlier, this is a hard space for everybody to navigate, given all of the attention from so many different angles. Both the media as well as the clinical community all have different approaches. And we are here, even this panel conversation is on GLP-1s in particular. One of the things employers struggle with is like, is this my only option? Are there other options? And this is where comparative effectiveness can help employers understand other options to bring similar levels of efficacious outcomes to patients in terms of access and coverage that may not be the things that get talked about on TikTok, but have an evidence basis for them. So for an example, I shared, in the GLP space, there's on one end, you've got very, very efficacious GLP-1s for weight loss. On the other end, definitely not as much with 10 pounds, but there is a non-GLP option that very few people know about that has about 18 pounds of weight loss. So almost double the least effective GLP-1. And it kind of runs you about $2,000, a year versus like 15,000 or so for the GLP-1s. So that's one barrier, is just really understanding the full suite of options you have in terms of coverage to ensure that you're aligning your coverage policies with the most effective medications at the lowest cost, regardless of the class, regardless of the hype. So that's on one side. On the other side, a lot of employers are recognizing that, and what I really respect about working with employers is that they understand it's very myopic to just think about drug coverage. They're really trying to understand, especially with conditions like these, the lifestyle components that have to surround that drug coverage in order to truly sustain the benefits that we're really looking for, which is that sustained weight loss that reduces all of the exposure to those other conditions that the clinical community is trying to address. One of the gaps in being able to bring forward more comprehensive solutions is the ability to evaluate lifestyle programs at the same level. Another area where comparative effectiveness research can really help. Many of the programs out there that tout a lifestyle management component, whether it's through an app-based strategy or an app plus clinician-based strategy, many of them have actually run relatively high, some of them not terribly high quality, but some of them have run very high quality clinical trials. And this, again, is a place where we can help employers evaluate these lifestyle programs, not only on how beautiful their apps are and how well designed and slick they may be or integrable they may be to other solutions, but truly, like, how likely are these to lead to clinical outcomes? And for example, we did a review of, I think, close to 25 different lifestyle management programs out there. the best of them actually showed 13% of body weight lost at year 1, 10% at year 2 with no medications. So it actually exceeded what we typically see on average, about 5%. This one, this particular one had some really great data without medications. So you can imagine for a patient who needs significantly more, coupling a very highly efficacious lifestyle program with a highly efficacious drug can really help to bring that benefit, get you the best, biggest bang for your buck, so to speak, from a cover standpoint. So I think the two gaps being, what are your options in terms of the drug, but then what are your options in terms of other ancillary programs? Those are the two things that employers really struggle with, fiduciaries really struggle with when trying to put together comprehensive strategies that really promote best clinical outcomes for their members. I say members, sorry, because we kind of think about it from the fiduciary standpoint versus patients.
That's great. Thanks, Catalina. I can see how your work can be super helpful. We have participants that represent payer groups and employers. So I can see how your work is super valuable. So thank you. So Dr. Wright, we've been talking all day about the barriers that our patients are facing. And I have like 2 questions that maybe you can touch on. And the first is, you started to mention, language being a barrier. And I know in your Latinx clinic, you're able to utilize providers and front desk staff and other members that speak Spanish. So 2 questions. For providers, can you give some recommendations on how we can support our patients despite some of these barriers that we're facing? And then also for groups that are maybe trying to create specialty clinics or systems to help support some of these patients that we know sort of struggle more with barriers or have specific disadvantages. Maybe just some advice for things that you've done maybe even in your clinic to be useful to those people.
Yes, absolutely. You mentioned the barrier of language, right? And I think this barrier is probably one of the biggest ones, and I feel that is also unappreciated. In so many levels, language affects how the patients do once they are diagnosed with diabetes. And diabetes being a chronic disease, continuity of care and having a relationship with the patient is very important to create trust and to understand like the importance of taking good control of diabetes and preventing complications and so on. So even in our clinic, where we provide bilingual care, myself and Dr. Morales, we are both bilingual and bicultural. And the staff, or medical assistant or nutritionist. But even in our clinic, we are working on getting things better. But for example, or the patient portal, like my chart is still in English. So that's a barrier. So advice for providers on how to overcome some of these barriers. I think finding out what the barriers are, right? Like, so I mentioned right now, for example, that I feel that the fact that the patient portal is still in English, that's a barrier. So understanding what the barriers are in the place, where we are working, and try to overcome those barriers. And when it's a barrier that is going to affect many patients, like when it is actually a system, well, those barriers and those, then they should take priority, because then that will help like a lot of patients. Also, I feel that, like a lot of the programs that we have, like the nutrition programs, the standards of care for diabetes, everything, that the recommendations that we have, sometimes they might not necessarily be, haven't been necessarily done thinking in minoritized communities. So then we need to realize that we need to individualize care, that we need to shape our recommendations, because there might be things that are more important in certain groups than obtaining a lipid panel, for example, right? Like that it might be more important for certain patients to focus on transportation. So understanding that these programs need to be shaped depending on our groups. We try to do that in our clinic. So I think those are some of the advices that we have for the for providers. When we are not when we don't speak the language of the patient, having interpreters is very, very important, and also because the visits will take more time, right? Like because we are using an interpreter, we need to go there, with thinking that it is going to take more time, and that shouldn't take. And because it's going to take more time, we shouldn't not do what we need to do because it's going to take longer. I have also patients in Harborview, and there I have patients who don't speak English and don't speak Spanish, and I use interpreters, and I really try to think that ahead of my visit. Because we have seen that patients who don't speak English, they do, there are many disparities in diabetes care. And it is thought that it could possibly be because of time management. To give you some example, like patients who are Spanish speaking, they are offered insulin pumps, continuous glucose monitors less often than people, patients who speak English. And that, when we think about a busy clinic and how long it takes, to talk about an insulin pump to a patient and all the training that the patient is going to need to, well, if that, is in a different language, it's going to take longer. And we need to be aware that that could be a barrier, and we should fight that. We shouldn't, we should be aware and conscious of that, and create programs that are going to benefit these minoritized groups. I mean, I can come up with so many more, right? Like so many tips on how to overcome some barriers. But those are the ones that come to mind. Chip, sorry.
Yeah, no, that's great. I was listening to you intently because I know you personally, and I know your work, and I think it's really important that you give that perspective, because I think your clinic is really focused sort of in this Latinx community, but the barriers that you talked about and sort of prioritizing care despite those barriers really translate to work with all of our patients. So thank you. I'd like to just transition now to open questions from our audience. We've had the opportunity to share with you guys 3 experts in the field. And so if anyone has a question, we have many members on the group now. I think what I would ask you to do is just use the function to raise your hand, and then we can call on you and then invite you to take yourself off mute. And I'm just going to call out, because I see one of our colleagues, Dr. Leo Morales, who Dr. Wright knows also. And I know that you've been heavily involved with the Latinx clinic as well. And so definitely if questions come up where, other specialists feel compelled to answer a question, I want to share this open space for that as well. This portion was kind of thought to be, open question and answer period, and then kind of move into really kind of peer collaboration. So I think that we can also be organic, and if people sort of have questions, we can use this space to, interact with each other.
See Leo's hand.
Oh, okay. Thank you. Yes, Dr. Morales.
Hi, everyone. Thanks. It's really interesting to listen to all the commentary on this really important topic. I think I did want to comment on a couple things. One is, it's really unfortunate that we have to condition our recommendations to patients based on what coverage and costs they can afford. And I think that really goes to the heart of an equity issue, because as providers, we aren't able to offer what we think is medically most important or appropriate. So I think from an equity perspective, that's something that is a real conflict, I think, in the practice, especially with the population that we serve in the Latinx clinic. The other commentary I was going to make is, you know, getting some of these drugs approved is really complicated. So there's processes you have to go through. You have to try some maybe more complicated drugs to take. So daily GLP-1s before you can offer a weekly one. I had one particular case where I had a young woman with diabetes who had cognitive difficulties, and the medical insurer required us to try once a daily versus going to a more simple regimen of once weekly, which would have worked for her much better. Those are frustrating situations. And I also wanted to mention the issue around lifestyle modifications, lifestyle interventions. The ones I'm aware of are not really tailored for the kinds of communities that I work with in the Latinx diabetes clinic. And, like the DPP, for example, very complicated regimen, very hard to follow through with, especially for lower income. And the food recommendations are not necessarily culturally appropriate, and don't resonate with the populations. So I think it's really important to keep an eye on this equity issue as we talk about sort of policy issues related to GLP-1s and CGMs. Thanks for that.
Yeah. Thank you, Dr. Morales. I think Emily actually had a question.
Yeah, I had a question. Dr. Morales, anybody can answer this, a panelist or Dr. Morales, if you want to add this. A common theme that I'm kind of hearing amongst our panelists in commentary is just the significance of cultural appropriateness to care and tailoring your care to respect and honor the person's culture. So we've heard some examples from Dr. Wright, what can be done to support a person with their cultural needs and how it intersects with their health. I'm curious if there's any suggestions or ideas from the panelists from the fiduciary standpoint of health plans or employers, purchasers, what others could be doing to kind of support this for their clientele as it comes to this whole topic.
I'm happy. Well, one thing I would say is, a lot of the data, including comparative effectiveness research and so on, is dealing with averages, means, and populations, and differences in means. And often ignored is the differences across populations. And here I'm really speaking to disparities. So I think as interventions are evaluated, it's super important to realize and think about what groups we're talking about here. So I think as a issue, and I know there's more awareness now around this, but looking at disparities and equities, population subgroups, and seeing what works in those populations is a guide. I know as providers, we're looking at our patients as individuals, and so I think there's an awareness that there are certain things that are just going to be more appropriate, be it due to financial reasons, cultural reasons, or other issues. CGMs, for example, and remote monitoring and not requiring patients to necessarily travel to the clinic to be able to see a lot of data very easily and quickly. I know I have a patient in Grays Harbor, another one in Yakima, and a third one up in Snohomish. Makes our care interactions a lot easier. So these are things that are not always considered when evaluating effectiveness, for example.
I think that's great. Thanks for that. I think many of us here in the group here, in some ways are developing research or sort of involved in these research spaces. And I think it's really kind of important to hear that perspective so we can sort of create, studies so that as information is being reviewed, that these populations are so represented and documented in that way. So thanks for that perspective, Dr. Morales. I think we have another chat question.
We do have a question in the chat from Cynthia. Can the presenter speak to the effects of semaglutide on chronic kidney disease in patients with type 2 diabetes? And I think maybe Oh, go ahead.
I guess, so Dr. Wright, would you like to take that question?
Yeah, absolutely. Yes. So now we have like new data that semaglutide has some benefits in kidney function. A lot of these studies were not really designed to look specifically at the kidney, but as secondary outcomes, there is a somewhat protective effect of GLP-1s on kidney function and microalbuminuria progression, the decrease in microalbuminuria. There are also studies recently that in patients without diabetes, with chronic kidney disease that had shown some benefits as well. So I think from the perspective of a clinician, it's always reassuring when we have like more data that shows benefits. We already knew about, the benefits of diabetes in cardiovascular disease, but kidney wasn't so clear. So now I think we have like additional new data that is exciting. And I think we will keep hearing about this with further studies.
That's great. It doesn't look like we have any more questions in the chat, is that right?
Mm-hmm.
Okay. I was just curious, and maybe Dr. Scher, you can speak to this a little bit. And I also kind of want to get back to continuous glucose monitors. We just want to make sure that we have equal time allocated to that subject matter as well. But I was curious, how does weight bias contribute to inequities in the access and use of both GLP-1s and then CGMs if you're using CGMs in that space too? I guess not.
That's a really great question. I think the most powerful way that I heard this put once was that, weight bias is used to rationalize denial of care for patients with obesity. Currently we have a system where obesity treatment is not covered, particularly because it's been sort of deemed a lifestyle condition or cosmetic, and kind of the underlying belief system behind that designation is that people's choices cause their obesity, and sometimes people feel that bias or stigma around having diabetes as well. The corollary being the folks that weren't successful losing weight just weren't trying hard enough. And so the scientific consensus in the field is that, obesity is a disease, it's treatable. And the reason behind that is that once weight is gained, there's a very potent physiologic system that resists weight loss and tends to promote weight regain. And that's part of what this disease process is about. So I feel like when we talk about how weight bias gets in there, part of it is that we're still using these sort of old conceptions, and we haven't shifted our views on obesity to keep up with what is now 20 and 25 years worth of science in the field. The other place where I think weight bias can creep in is when we're having discussions, whether it's CGM, whether it's GLP-1 agonists, about the questions that Catalina brought up. What's worth paying for? And the side of that is who is worth paying for these services for, or who do we provide access for? And so we're in a sticky spot here with obesity, because when you're saying I'm not going to pay for obesity, you're saying I'm systematically denying care to a vulnerable patient population that experiences discrimination based on that diagnosis. And within that population, individuals experiencing poverty, experiencing food insecurity, people who have racial and ethnic backgrounds that put them at further risk for discrimination and health equities are overrepresented. And so in this area, it's worth, I think, being very vigilant when we're making these decisions about, as best possible, just being honest with ourselves about the fact that weight bias can, creep in. And, that's why they call it unconscious bias. It creeps in even when people are well-intentioned or trying to be rational about it. So I think that's where it's very sticky right now as we talk about these decisions.
Thank you. I'm going to ask a question because I feel like I get this often. And so I'm just interested to kind of hear your take on it. And this relates to both Catalina as well. And the question is sort of what's sort of the duration that patients sort of can expect to be on these medications? And I ask the question because also Catalina, sort of as you're helping, payers develop, like a cost approach to, taking care of their patients that have, diabetes and obesity. Are some people kind of, if they're not thinking about these conditions with sort of a chronological time frame, I guess I'm rambling on, but essentially the question is how long are patients sort of on both GLP-1s and CGMs? Is there any harmful, to being on these medications for a long period of time? And then for Catalina, so assuming that they're on these medications, well, how do you sort of help estimate then for payers the lifeline of that medication? Because I think that people are still thinking about obesity and diabetes as sort of an acute event. You take your medication, whether that's insulin or GLP-1, and then you graduate from it. So maybe just tell me sort of your guys' perspectives, Catalina, and then maybe Dr. Scher.
Yeah, great questions, because I think this really kind of gets to like the heart of the issue from a fiduciary standpoint, which, it's admittedly hard, and you have to look at it from a population level. And that means population doesn't mean none of one. So employers are in a really tough spot because their obligation under ERISA is to the plan as a whole, right? As an individual, it's a different kind of piece, side of this equation in terms of what they're trying to manage toward. And I think what you're describing is in terms of that long-term effectiveness does play a role, right, into those coverage decisions. So, your first question was, is there harm if people are on these for a long time? Right now, from a data standpoint, the answer is we don't know. People haven't been on them for a long time, so we just don't have long-term data, long-term quality data to be able to speak to that. And that's still something we're learning about. And as people do take these for longer periods of time, we will be able to understand, much better which patients will benefit most, which patients do the benefits don't outweigh the harms. But long-term data is really required to be able to build those from build those viewpoints from a data standpoint. In terms of what we're seeing just from the payer side of how long people are on these medications, we see people dropping as early as 3 months in, not able to tolerate the side effects. Very, very few people last to about the year mark or later. And those who come off, we've seen in real world studies, they tend to regain that weight, unfortunately, which really speaks to just work and why employers are looking for more comprehensive solutions. So that's still to come. I think in some of the conversations that we're having around what else might be out there, what would certainly, I think, change some of these cost discussions is having more options. What's interesting and be interesting to see is there are 8 FDA approved drugs for weight loss. There are 8 in phase 3, which means relatively soon, but there are 124 different molecules in development, various stages. So as some of these come through the pipeline, it will certainly change this conversation, dramatically. I think, Zepbound and tirzepatide coming to market has changed the conversation, as you can see. There's a question about long-term data. In terms of long-term data, just to answer that question directly, long-term data within the published literature is what we still haven't seen in terms of that patients staying on it and seeing those long-term effects, even though, yes, they've been out for many years. The data of people actually staying long-term, that's still lacking.
Thank you. Dr. Scher or Dr. Wright, did you have any kind of thoughts to that?
Yeah, I'll just, add the perspective on, I think this falls back to our shifts in the paradigm of understanding that, obesity is a disease process, a chronic disease process, similar to diabetes and similar to, other cardiovascular risk factors like hypertension. And so, to be honest, my patients don't want to be on this drug forever either. They're like, when can I get off, doc? And so, I kind of have to break it to people, this is our current understanding, which is, these medicines help with weight loss, but they also help with keeping the weight off. And what we are looking for is sustained weight loss for sustained health benefits. And we've seen in long-term studies of bariatric surgery, which is the only other option that we have that really does that it's not so much that the risks accumulate over time, it's that the benefits accumulate over time. And so in bariatric surgery, where we have weight loss, even if not all of the weight loss is sustained, you now have not only cardiovascular risk reduction, but also mortality reduction. So I think both things are possible, that there can be risks that will be revealed with long-term outcomes, but I also think that there could be benefits that are revealed with long-term outcomes, and those data are all still pending. In terms of the weight regain, again, I think this is where people treat obesity a little bit different. And, so we don't take our patients off their blood pressure medicines and ask them to use willpower to keep their blood pressure down. And so, it's a weight medicine. It works when you take it, and when you don't take it, your weight goes up. So, this is part of the conception. All the recent FDA approved medicines are approved for long-term use. And I think as a field, we've come around to that, but we maybe have to do a better job of bringing along the primary care docs, bringing along, the hospital systems, bringing along the fiduciaries, bringing along everybody in the system to understand, that's what we're talking about if we're really talking about managing obesity in the long run. And my own research is on how exposures and weight gain change the brain in a way that remodels the brain centers that regulate body weight. And so, concurrent with these changes is science that's going on to really understand the fact that, this system that regulates our behavior in order to get us to have sufficient nutrition to survive, how it's modified in this disease. Because I think in the end, that's also going to make a difference in the way people conceptualize it.
That's great. Thank you. Well, I'm going to close this panel discussion with just one final question for each of you, but also want to put a plug in if anyone has any final questions that they want to add to the chat. Please do so now. And, I know we have a lot of members that end up, watching this sort of after it's been recorded. So really, I'm grateful for your guys' time. But our question, so for each of you, what is one next step that you think is the highest priority to improve equitable access and use of both GLP-1s and continuous glucose monitors? Maybe Dr. Wright, we'll start with you.
Yes, absolutely. I think I would say that we need to focus on specific groups, right? Like minoritized groups have more challenges, and then those groups need more help, right? Like, or different type of help, and we need to focus on what are the needs of these groups, and target those specific issues, because when we just apply the same for everybody, we've seen that just doesn't work, right? Like, it's like a group is favored and the rest and the other groups are not, they don't benefit the same. So that's what I would say is the priority.
Great, thank you. How about you, Catalina?
Well, I'll give everybody a next step that's more of like a pipe dream. But I think specifically to answer some of the questions some of these people have asked, in terms of, I think Dr. Morales, you brought up like the, the fact that data is in averages, right? Wouldn't it be nice to know more at the individual level? As when pharma runs these studies, they do have all of that data at the individual level. There are a lot of researchers we've worked with who one of their dreams is to get more access to that individual patient data. If we got that data, we could say a lot more about these medications, how they work. It would substantially improve payers' ability to build a clinical and data basis for coverage. And that would significantly today unearth opportunities for us to create greater access, to remove these barriers, and do so in a way from a fiduciary standpoint, but still in line and in meeting with those obligations. But it's a pipe dream, so I don't know if it's the next step.
I guess what I would say would be to, sort of better align our care, and I'm going to again speak to obesity specifically, with current recommendations and guidelines. So, we recommend lifestyle, but nutrition and dietitian consultation isn't covered when it's for obesity or weight loss. We recommend adding pharmacotherapy. And even if we're not going to use the more costly medicines, ones that are like phentermine, for example, that's generic and has been around since the 50s and costs $15 a month, is still excluded for patients. And so I think there's some room for us to think about these tools in a way that will allow more equitable decisions to be made. So at least even cost-effective pharmacotherapies and or less costly. The cost effectiveness is not really determined compared to GLP-1s, but less costly options are more widely available, and we can really start using them to reduce disparities related to obesity.
Great, thank you. And I'll just actually put it out there to the group. If anyone else has, next step recommendations, happy to hear your insight or knowledge if anyone feels like they wish to contribute.
Dr. Morales?
Okay, Dr. Morales, I see your hand
The one
up.
thing I would add is standardization of coverage for CGMs, Medicaid coverage with Medicare coverage. Right now, Medicaid is not in line with Medicare, and so I think that would help.
Yeah, thanks, Dr. Morales. Anybody else on the call that has thoughts? I think we have people from kind of across different parts of the healthcare ecosystem that RSVP to this and are probably at the table right now. So I'm curious if anybody who hasn't had the chance to speak yet have any questions or thoughts on what a next step might be that you'd like to see as we move forward. Well, thank you all for joining us today. I think it's been a wonderful discussion, and I think we'll go ahead and give ourselves a little bit of time to wrap up for the day. We want to really appreciate and thank all of our panelists for being here and sharing their time and expertise with us. And I think there are a lot of you each have very unique, different perspectives from the fields you work in, and it's good to get people together to talk about, what they see and what's important from their unique points of view. So I really appreciate you all taking the time today to share that with us and join this conversation. I will go ahead and get us sort of wrapped up for today, and just highlight some upcoming events that the BRE Collaborative is putting on. In June on the 12th, we have the Catalyst for Change Analytics at the Intersection of Equity and Value, and that is co-hosted by the BRE Collaborative, Comagine Health, and the Washington Health Alliance. And Emily will actually be supporting that webinar, so you can join us on the 12th for that. We'll be dropping the links to that in the chat very soon. On June 25th, we also have a learning lab kind of continuing our conversations on equity and how we can best reach people that have the most need. We'll have a learning lab addressing food insecurity in Washington State that is also a panel discussion. Go ahead, Emily.
Just with that, we have the opportunity to provide continuing medical education and continuing pharmaceutical education for individuals who attend that event. That will be from 12 to 1:45 p.m. And we have a speaker from DSHS, from Washington Department of Agriculture, from DOH, and then also a veggie and fruit prescription box, which is a community organization that's working with a health clinic to provide that, I believe, for patients with diabetes, just because I think as we've been talking in this space, we're highlighting the need for support in people to attain healthy lifestyles, and food is a critical component to that in their diet and accessing that. And so we look forward to having a dialogue there on that as well. And then we have some information on ongoing evaluation initiatives that our staff member, Carrie Nicholas, has been leading. We recently had a report on perinatal behavioral health, and we're looking to get some data and baseline information collection so we can see how we've been improving in Washington State over time. We recognize that I believe it is the number one cause of death for in maternity care is related to behavioral health in Washington State. So it's a very highly important topic. And then also there's an opportunity to self-report data through our new implementation guide to be eligible for our 2025 Trailblazer and Mountain Climber Awards. We just awarded some of these a couple of days ago, but we're excited to do it again. If you have any questions, please email Carrie. We'll provide all this information for each of you in an email if you signed up for today's event with the recording. But we are grateful for each of you joining us and for our speakers today.
Yeah. And one final thing we'll drop in the chat is a post survey on our event today, so you can give us some feedback on the learning objectives and the structure. But we appreciate any feedback you have, and thank you again for joining us, and thank you especially to our panelists again for sharing your time and expertise with everyone today.
Thank you.
Thanks for having me.
Thank you all.
Yeah, thank you all.